All right, so we'll go ahead and get started. Good afternoon. I'm Jennifer Greif-Green. I'm a professor at BU Wheelock in the College of Education and Human Development. And thank you for joining the webinar this afternoon, which is on school reopening and mental health. This webinar is part of the Equity and Social Justice webinar series at BU Wheelock. And every week this summer, BU Wheelock has been hosting webinars as part of this series. So if you go to our website, you can see upcoming webinars, and you can also find video recordings of previous webinars. The webinar today will run for the next hour, and we have three terrific panel members who I'm very excited to have speaking with us today. They'll each speak, and then we'll have a question and answer period. As you're listening to the talks today, you're welcome to enter questions into the Q&A box that you can find at the bottom of your screen. And as you answer those questions, I'll gather the questions for our speakers to answer. If you have any trouble with technology, please feel free to use the Q&A box as well, and we'll do our best to support you with technology throughout the webinar. The webinar today is on the topic of school reopening and mental health. From decades of research, we know that child and adolescent mental health is worse in times of crisis, and that the impact of crises on mental health can be long-lasting. The effects of COVID-19 on mental health are similarly expected to be significant, and some early data do indeed show increases in mental health problems among both children and adolescents. At the same time, access to mental health services has been more difficult, as mental health services have primarily needed to shift to a telehealth model. And already we know that mental health services are less accessible to children of color and children living in low-income communities. We expect that those disparities are currently being exacerbated. As schools reopen over the next several weeks, we can expect that students and staff will be returning with increased mental health needs, with many families likely having experienced loss and trauma, racism and unemployment, and other personal and financial crises. Whereas most years, schools are on break for about 2 months from spring to fall, this year schools will need to figure out how to reunite and address the mental health needs of students with whom they may not have been in contact with as many as 6 months going by. So it goes without saying that these mental health needs of youth are going to need to be addressed in the context of an extremely complicated school reopening this fall and an ongoing pandemic. Our plan for the webinar is to discuss some of these complexities that schools and communities are facing in deciding how to address the mental health needs of students, and we will specifically be focusing on reducing inequities and access to mental health services. So we hope that today we'll be able to provide you with some new information about approaches and considerations that might be helpful, and also to raise some new questions as part of the discussion. I am so grateful that we have three terrific panelists today, all of whom have been giving a great deal of thought to supporting youth mental health in the school year, how schools can collaborate with community partners, and how to reduce inequities in mental health service access. So I'm going to introduce them each now, and then I'll let them progress through their talks. Our first speaker will be Dr. Sharon Hoover, who's co-director of the University of Maryland National Center for School Mental Health. Sharon's going to be discussing approaches to planning multi-tiered mental health strategies for schools and districts as they begin this upcoming school year. Second, Dr. Kiara Alvarez, who's here from the Disparities Research Unit at Massachusetts General Hospital, MGH, will present on her research on racial and ethnic disparities in access to mental health services. And in particular, she's going to talk about her research on suicide prevention among first and second generation Latinx adolescents. She'll be talking about how her work and how approaches taken in communities have needed to shift as a result of COVID-19. And finally, we have Dr. Jill Battal, who's here from Boston Public Schools, who will be describing efforts that were taken by the district to provide behavioral health supports and services to students this past spring when schools were operating remotely. And she's also going to discuss plans for providing supports this fall, as well as anticipated challenges and opportunities facing the district. So again, I'm so grateful to these speakers for joining us at what is a very busy time for people who are working in schools and working on school mental health. And Sharon, I will turn it over to you now to get us started. Thank you.
Great, thank you so much, Dr. Green. And I am going to go ahead and share my screen. So it'll just take me one moment to transition here. Okay, so again, thank you for the invitation to speak with you all today about school mental health as school restarts. We know this is a challenging time for so many, and for those of us who spend our time really at the intersection of mental health and education, this is a particularly trying time to think about how we can best meet the needs of our young people, our families, and all of the adults who support them. As Dr. Green mentioned, I am privileged to be a co-director at the National Center for School Mental Health, and you can find a little bit more about what we do at schoolmentalhealth.org. And we have spent some time over recent months compiling some of what we've considered to be really wonderful resources to put in the hands of educators and behavioral health systems and leaders and providers and families and students who are trying to navigate their work in school mental health in the context of COVID. So here's what I'm going to talk with you about in the few minutes that I have with you today. I just wanted to quickly touch on student and educator mental health needs as we restart school. Dr. Green already alluded to some of them. I will give a big picture view of comprehensive school mental health systems and some of the things that we know are best practices that we need to hold on to, but also things that we need to layer on now, and then quickly move through the tiers of support that we know are going to be essential as we return to school. So as far as our student and educator mental health needs, we know that we will likely see an anticipated surge in behavioral health concerns in our young people and in their families. This is just a snapshot of some information from a survey of young people aged 13 to 19 that actually took place in late April, early May. And what you can see here is that about a quarter of these young people said they felt disconnected from peers and adults. About half were more concerned than usual about their family's physical and emotional health. Not surprisingly, about 1 in 4 said they had an increase in sleep loss due to worry, feeling unhappy or depressed, constantly under strain, loss of confidence in themselves. And frankly, we're seeing many more data come out that are giving us a glimpse into some of the stressors that our young people are experiencing. We also know from past health crises, both nationally and globally, that young people and adults are likely to be experiencing a variety of increases in mental health concerns. So, for example, when we look back on the impact of pandemics like the influenza of 1918, H1N1 flu, the 2014 Ebola virus, they were all associated with increases in depression, anxiety, stigma, shaming. We also know that we can anticipate longitudinal negative impacts based on what we saw with other large-scale community crises, natural disasters, for example. So from Hurricane Katrina as one example, there's good data to demonstrate that young people who experienced those natural disasters, especially those who had the most disruption in their academics, had a negative impact on their behavioral health and academic functioning. And in addition to COVID, our students in schools are in the midst of a national crisis of inequity and racism. And we know the rampant injustices of racism are not new, but are seeing a new day of awareness and uprising that creates hopefully an opportunity for change. So today, as I speak about restarting schools in the context of crisis, we're really talking about multiple crises. Including COVID and racism, and what schools and school mental health systems and educators can consider to respond. And in addition to students' experience, we know that the experience of our educators is really important right now as we think about how to support systems. This was a survey that came out of some educators in New Orleans, and they described some of their greatest difficulties in teaching during the pandemic: lack of connection, and we know this is especially true in communities impacted by inequities, online teaching challenges, but also they describe a tension between academic expectations and student well-being. And I think as systems, we are struggling with that very issue right now. How much investment in time and resource do we put in student well-being relative to academics and instruction? This was some of the information that came out of a recent large webinar of teachers and school leaders when they were asked, what stressors are you and your colleagues currently experiencing as you prepare to reopen schools this fall? The school leaders, as you can see, the bigger words here represent the more responses of these particular responses. So uncertainty, unpredictability, safety was a top priority of school leaders, and many expressed concern not only about student mental health, but also about educator well-being. These are the responses from our educators, and as you can see, many again are related to student mental health, student suffering, and unresponsiveness and inability to engage a number of students. So let's talk about what is happening in terms of comprehensive school mental health systems. One thing we know is that there are many things we lose touch with in the context of a crisis, whether it's an individual crisis, a family crisis, a community crisis. And we know that even despite these unprecedented times, we can be reassured by the fact that there are some core principles and practices that likely remain important and relevant and effective during this time. Just like with individuals or families experiencing crises, we try to go back to some of the rituals, routines, practices in their daily lives so that we can reorient them. So similarly, with our school mental health systems, we want to look to those core principles and practices that are effective pre-COVID times. We also know that there are things that need to be layered on now during this challenging time. And the good news is we've seen tremendous innovations during this time in terms of how we can support our young people and families and educators. So a couple of the core practices and principles are highlighted in some of the resources I want to quickly share with you. This is a guidance document that came out actually last fall that goes over the who, what, how of school mental health. And this was a collaboration of several federal, national, state, local partners to develop kind of what is a framework for school mental health and how can we adapt this to local context. So you can see the link there. I'll put these links in the chat box after I'm done speaking this afternoon. There's also a school mental health curriculum that went out in partnership with the Mental Health Technology Transfer Center Network, and this is for district leadership to really build and improve the quality of their school mental health systems. That curriculum is directly aligned with a free platform that any individual or school team or district team or state team can go in and assess their school mental health quality improvement. They can map services, they can assess how they're doing, and then as a team make quality improvement efforts. And we have seen a number of new teams sign on in the context of this very stressful time to figure out how they can make improvements in their system. So moving into the tiered systems of supports that we're seeing in schools, at Tier 1, we know that, again, there are some practices and policies that are critical now and always. And some of these include positive school climate, culturally and trauma responsive practices and policies, well-being of our staff and educators, social emotional learning supports, crisis preparedness, and mental health literacy. And I know that's a lot, but these really are the essential universal strategies that we know remain consistently important, whether our young people are distance learning, hybrid learning, in-person learning, and maybe especially important right now because we're going to see heightened fear, anxiety, worry, sadness, disconnectedness, loneliness, among other things. What I'm showing here is just a reminder to us all that as we first think about what can we do universally, we have to think about our educators. And one of the statements that an educator made that will always stay with me is, please don't tell me to just do more yoga. Now, I'm a big fan of yoga, big fan of mindfulness, but I think that this is a good reminder to us that while elements of the school environment and structure seem to cause considerable stress for our teachers, the mechanisms that we commonly suggest for educators to reduce their stress focus on teachers' responsibility for self-care. And we know self-care practices like meditation, exercise, or participation in a support group may be inexpensive and sometimes straightforward to implement. They do have the potential to alleviate stress, but we also know that they often don't address the root causes of our educator stress. And so we want to think about systemic efforts to improve teacher well-being. And I mentioned teacher well-being before I get into anything about student well-being, especially now. We know our educators are under tremendous stress. We cannot expect them to support the well-being of our young people unless we are first and simultaneously supporting their well-being. And there are many resources right now, and I'll stick some in the chat box at the end that can lean us in this direction. Mental health literacy, I want to make you aware of a resource that's coming out this fall. First of all, there's a repository of free training for educators on mental health at the Mental Health Technology Transfer Network site. But there's also an online course that'll come out that'll be free to all educators, focused on promoting mental health and well-being of all students, but also understanding and supporting students experiencing adversity and distress. We've seen some tremendous translation of Tier 1 strategies during school closures. Our colleagues at Child Trends remind us that we may need to reframe the 3 R's and think more about reassurance, routines, and regulation. And also that, that we can, whether we're virtual or in person, we can still implement some of these social emotional learning strategies for young people, and probably, again, may need to spend more time as we transition back, given, as Dr. Green said, we've been out for several months. One of the resources I find most helpful for teachers right now who are saying, what can I do to support my students, comes from the Psychological First Aid Listen, Protect, Connect, Model, and Teach. I'll put the direct manual link in your chat after this, but this is some concrete guidance for how do you go back into the classroom after a crisis. I want to also just mention a couple of resources at the universal level in terms of thinking about how can schools also be attending to racism with their students. We can't just be focusing on the COVID crisis alone. There are many organizations, agencies, coalitions designed to support anti-racist work in schools. This is but one, and this lists out the 4 demands of Black Lives Matter at school. So I encourage folks to be thinking about how can we be responsive across all arenas and not just in the context of COVID. Another area that many schools are thinking about is how can we support youth activism as a positive coping strategy for young people as they deal with the pandemic of racism and as they want to support their communities. I will, recognizing that I'm almost at the end of my time, just very quickly mention at tiers 2 and 3, we know a lot of schools right now are asking about screening. What should we do? Should we do wide-scale screening? How do we identify young people in trouble? We do think it can be an opportunity to implement well-being checks in your school, but we also would caution folks not to dive in too quickly because there is an infrastructure that should be in place. I'll put a screening playbook into your chat box when I'm done, but these are some of the constructs that schools are considering measuring. We also think that daily or weekly check-ins right now can be really useful. There's some sophisticated platforms to do this, like CloseGap, but also Google Forms. You know, there are different types of forms that teachers are using to check in with their students. And then finally, we know that interventions in schools are perhaps now more critical than ever. This is data from post-Hurricane Katrina, where they found that young people were 6 times more likely to complete mental health treatment in schools than in community settings. And we know there are interventions designed specifically for schools. Now, what about if you're in the context of distance learning? The good news is many of our providers have become more savvy about how to implement, including our school providers. And there are a number of interventions that have now been redesigned to implement online. This is from one of your partners in the Boston area who reconfigured CBITS to be delivered online, and there's a free manual. Again, I'll put the link in. And also one of the areas that our school mental health providers are turning to is how do we better address racism in the context of our interventions in schools? And there's great guidance out there on how to do this, and I'll put some links in for you. We also know there are excellent interventions that can help support an anti-racist lens in the work that we do. And I'll close by just reminding us that all of the work we do hinges on our relationships, and we need to foster those people who are fostering relationships with their young people, including our educators. So thank you so much, and I look forward to the Q&A session shortly. But please feel free to put questions in the chat box. I'm happy to answer those as well.
Thank you so much. That was great. I'll just give Kara a second to get your slides up there. And it would be great if you could put the resources in the Q&A box, because we disabled the chat, but the Q&A is open so people can see any of the resources that you put in there.
Great, will do.
Great, thank you so much. And Kara, I'll turn it over to you now.
Okay, thank you so much. I am presenting today on service disparities in youth mental health, and so picking up on some of the themes that were introduced. My name is Chiara Alvarez, and I'm a research scientist at the Disparities Research Unit, as mentioned, at MGH and Harvard Medical School. Oops. I'm having having trouble advancing the slide. So the overview today for my presentation is that I'll talk briefly about disparities in youth mental health services and how specifically that may play out in the COVID context. I'd like to give an example from a research study in progress and then provide some thoughts about addressing disparities as schools reopen. So when we think about disparities, the Institute of Medicine defines disparities in this way, which is really differences in treatment or access that are not due to differences in the actual health status or the group preference, so that at the same levels of need, there is less access to a service. And we know across multiple sectors that there is greater unmet need for mental health care among racial and ethnic minority youth, or rather youth of color that are in this category of being seen as minorities. Racial ethnic minority youth are also more likely to experience coercive service use, meaning families are entering services either via child welfare or juvenile justice system, as opposed to through our outpatient mental health system and other voluntary forms of care, and also may receive lower quality of care and be less likely to be retained in care. And this is really a very brief overview, but some of the specifics around this are really for a number of different kind of groupings in the population, thinking about youth that are Black, Latinx, Asian American, Native American, immigrant children, children with low English proficiency, children in low-income families. And due to barriers to care, these are not individual problems or family level problems, these are structural issues of structural racism and discrimination, interpersonal racism and discrimination, lower access to insurance, lower likelihood even of being referred to care when a problem is identified by someone external to the family, mental health stigma, and a lack of service availability in multiple languages, which remains a problem. In COVID-19, as has already been mentioned, we know that there have been stark disparities that really reflect what we have seen in healthcare and mental health over decades. So we know that Black, Latinx, and Indigenous families in the US have been disproportionately impacted by COVID, including higher rates of illness, more severe illness, more hospitalizations, and a greater number of deaths. And families are impacted very strongly by the social isolation and family stress, but particularly families that are struggling in this context with unemployment, food insecurity, and inequitable access to education. And so we know that families of color are overrepresented among our essential workers, as well as among our workers in industries that have really suffered under COVID, such as the restaurant industry, retail, and hospitality. Immigrant families in particular have been systematically excluded from federal benefits and creating situations where the disparities that already are existing are even further exacerbated. And we know, as mentioned, the high rates of mental health concerns that have been reported. And SAMHSA, I have a link here for a disparities brief, which I'll put in the Q&A. So as an example from my own research, I wanted to talk today, again, briefly, but just in terms of some of my thinking, having been working in the area of suicide prevention, and for several years working under this NIMH-funded study to develop an intervention, which I had aimed to start testing this year, earlier in the spring. And the goal of this intervention was really to develop an 8-session family therapy program for immigrant Latinx families, in which an adolescent was experiencing thoughts of suicide. So it was really meant to work with youth and their families when the youth is experiencing suicidal ideation, building on family and cultural strengths, improving communication and reducing conflict, and with the goal of that potentially leading to decreased suicidal ideation and ideally in the long term to reducing suicide attempts. This had really been developed originally as a series of in-person family meetings, and the goal was to respond to needs both documented in the research literature, but also expressed by parents and adolescents in qualitative focus groups. And of course, as we know, the possibility of doing this in person, very quickly became impossible and potentially won't be possible for some time in a safe manner. And so being new to telehealth, not being an expert in that area at all, some of my thinking as well as consultation with families, with community providers, with other folks in telehealth, we're thinking about the possibilities that this provides for family therapy as well as some of the barriers. And so knowing that actually one of our biggest barriers and one I was very concerned about for my study is that it's very difficult for a family to coordinate for all of them to be together in a family therapy session at the end of the day. We have varying work schedules, and for immigrant families, often non-standard work schedules and multiple jobs. Transportation becomes an issue, the time it takes to travel to a clinic. versus in family therapy, where it might meet families where they are in their home, but they might not have access to computers or tablets, because we know there are technology disparities. We know that families of color and immigrant families in particular have lower access to the internet. They might be using, often the families we work with, pretty expensive data plans and aren't able to spend an hour weekly in a session. I include, other potential challenges and barriers, but I think some of the things I'm thinking about have to do with the long days that we're experiencing, plus technology kind of fatigue. If kids are in school with remote learning and parents are having to navigate how to make that work, making a session for mental health purposes work as well is a big ask. And safety planning when we're thinking about mental health crisis. And I'm reassured by the fact that a lot of people are actually doing this very well, but the importance of having clear crisis plans and procedures. And then potentially expanding this to a wider range of patients so that patients don't have to travel a long time to see a provider in a particular community. Potentially clients can be seen statewide. So some takeaways to me in mental health services is really that we have an opportunity here, but we need to be thinking about, can we provide equitable access to technology and to stable internet connections? Can we provide technology support for families to learn video conferencing? Can we support therapists? All the therapists I know that have been doing telehealth full time, it's pretty tiring and a difficult process to engage in that doesn't have some of the same kind of payoffs of being in person and having that in-person interaction. So really providing that time to adapt and the group consultation. Providing case management support for basic needs, which have really increased in this pandemic, but were certainly always present for populations that have been more disadvantaged with relation to services. And then tracking our data, because if we see that there are differences between groups, racial, ethnic, or linguistic groups in engagement and in symptoms, we know that our interventions may be working for some groups and not others. And the thing that we essentially don't want to do is create greater access and greater innovation for some groups and not for others, because then we see our disparities widening instead of decreasing. So in thinking about this for the talk today, I wanted to think as well for those attending about, some practical ways that we may be thinking about approaches to reducing inequity. And so again, these are structural problems, as Dr. Hoover talked about, really needing structural solutions. But there is also a question of how we're interfacing in that context. So some of the things that I've thought about have to do with balancing connectedness and privacy. We talk a lot about connectedness in suicide prevention. It's a very important protective factor, but we're also in a time where we really have very little privacy at home or with work or school kind of entering into the home. And we want to balance both families' time together versus personal space, which in small spaces or spaces shared by many people may not really be possible physically, but there can still be the possibility of giving time for family members to be in a corner of the room and have their own time together. Very important for children and particularly adolescents. For schools, really that regular contact, but respecting family preferences, including, I think, some convincing opinions about giving options for videos when possible, in case families don't feel comfortable with that sort of visual into their home. I always advocate for collaboration and transparency and partnering schools and families together and solving problems, discussing family preferences for how to be contacted. And I think concerning, there have been multiple reports about kind of the role of child welfare when families aren't showing up, for instance, for for delivery of school services by the internet, or if they haven't logged into a program. And I think that really needs to be addressed and very clear information given to ensure that if families are contacted or emergency contacts are reached, the families know in advance what's expected of them. And again, understanding that both on the teacher and administrator and school side, there are a lot of barriers and concerns and a lot to deal with at this time. Another goal would be for providers and administrators to identify those referral pathways and gaps in student and community needs, to really provide access points. The more access points we can provide, the better, in order to get people really integrated into services. And to really identify and reach out to students who are isolated from the school community. And so if potentially instructional teams are able to identify that there are some students who don't necessarily have a touch point within the school, what can we do to include those students, especially in this time where they're not physically present in the school? Let's see. Consulting with community agencies and leaders for insights and recommendations, and then really partnering creatively around inclusive communities for emotional wellness. And I think there were a number of amazing recommendations made in Dr. Hoover's talk, but thinking about how did this happen at the level of communities and groups so that it's just part of the school culture. Because I think in some of my work in focus groups with families, they really were asking for lower barrier ways to access mental health support. Things like emotional wellness workshops or peer support groups were important ways to access services without necessarily initiating mental health services with a therapist, which also may be difficult to do due to availability. And then finally, always ensuring language access and disability accommodations for all services and not necessarily assuming what needs might be present or not in your school community. There is some literature about, for example, Latinx parents from indigenous backgrounds being mistaken as Spanish speakers and schools making that assumption when really that's not the language that they speak. And so making sure that there are ways to assess that. We're coming to the end, and I think finally, I just want to encourage the thinking about creativity and partnerships and problem solving. There are so many organizations, schools, volunteers, people are really stepping up to meet basic needs, to do many things in very creative ways in a very short time. I think that is, pretty amazing part of going through a crisis in a community. And so thinking about the ways that these linkages can be brought together and really thinking about volunteers, because the resources to do more around creating resource guides, for example, may not be there in a school, but there may be volunteers in the community that are willing to partner and produce things that a school can then use. And I think the last part that I wanted to include were some resources, which I'll put in the Q&A. One that's a pretty comprehensive resource from MGH about some of the research in different areas, and there is a section on mental health, as well as one that was actually already mentioned in the prior discussion, because it actually also has many webinars that are very useful as far as cultural competency and meeting the needs of families. Thank you.
Thank you so much, Kara. I'll turn it over now to Jill and just give you a minute to share your screen.
Great. Did that work? Okay. Hi, I'm Jill Batal. I'm a school psychologist in Boston Public Schools, and I think I don't need to reiterate to anyone who's attending this webinar how critical schools are to meeting those mental health needs that we've talked about and behavioral needs. So I'm going to talk to you a little bit about how we responded last year and also use that to talk about what we're thinking about for this year. Because so many of our students in Boston Public Schools do access mental health at schools, whether it's through district employed providers or partner providers who provide those services within our school buildings. We have a combination of that happening in Boston Public Schools. And so when schools closed, that meant that all of those students currently receiving services really lost their access at first. And so to respond to this, we really took a coordinated response across both district employed and partner employed providers to pivot very quickly to telemental health and ensure that the students who were already receiving services maintained those connections with their pre-existing service provider so that that connection could continue into the school closure period. Of course, that pivot was new skills for all of our service providers, whether they're employed by the district or partners. And so that initial learning curve of learning the new platforms, learning how to adapt some of the things that we do to a virtual format, I've never been prouder of the team that I work with for the way that people just jumped in and really figured it out. And so I think that's definitely an opportunity going into this year that we now have a lot of those skills under our belts. And another bit of context for our response, both last fall and then last school year and going into the next, is that my role and the work that I'm going to talk to you about is part of a comprehensive school mental health framework that Sharon discussed in the beginning. And so we have, this is the comprehensive behavioral health model was developed in partnership between Boston Public Schools, Boston Children's Hospital, and UMass Boston. It includes multiple layers of services, so thinking about prevention, about tier 2 interventions and tier 3 intensive services. In Boston, we are very fortunate to have a lot of tremendous partners right in our community. And so our partners help provide all of these services, which turns our triangle into a lighthouse. And you can see at the bottom some of the essential components that we talk about with our comprehensive behavioral health model are instruction. So those things that Sharon mentioned about social emotional learning instruction, culturally responsive social emotional learning opportunities, PBIS and school climate, things like that would fall into our instruction bucket. We do have universal screening happening to help us identify those students that need additional support. And then finally, database decision-making to bring those, the instruction and assessment together. So at each layer, at tier 1, tier 2, and tier 3, we're thinking about those essential components to really meet the needs of students and schools. And so what I'm going to share with you a little bit is information from our annual report, which you can read in full at that link. And it's largely based on fall 2019 data, which was obviously pre-COVID, pre-closures happening. But I'm going to talk to you in the context of our fall 2019 data about what we're anticipating and considering, as we move into the 2021 school year. So anybody working closely with schools will never forget last school year. It was a pretty memorable one. And so, like I mentioned, I'm extremely proud of our team that pivoted really quickly to first connect with families. So all of the families that we were already servicing, working with the students at schools, maybe we had a family contact, even if we weren't doing direct services. So our team of about 80 internal BPS mental health providers reached out to all families to connect with them to find out how had they been impacted, what supports did they need, as well as to offer telemental health services. So as we talked about, families had different levels of access to technology. So some families were absolutely interested in starting telemental health from day one. Some families needed a technology, needed a laptop or something before they were able to access that. And some really had the technology and weren't interested in that level of support because they had other pressing needs going on. And so our initial push was to contact families and give them those options and say, what types of supports do you need and how can we connect you to them? And this ranged from everything to laptops, because our district gave out a tremendous amount of laptops, to food, to housing, regardless of what the nature of the concern was. And so through doing that, through offering that, and then through also having new referral mechanisms to service new students who maybe weren't being seen during school, but since school closures had really had some needs pop up, we were able to provide over 7,000 telemental health sessions by our staff of 80 people. So we made a tremendous amount of contacts, but we also held a tremendous amount of actual services virtually. So that impacted through both the contacts and the services. We were able to reach over 3,000 families and over 1,000 students with services. So I'm going to talk to you a little bit about the context of our screening data. And again, this is fall 19, so before COVID happened. My role with CBHM is to help with the data collection and the research. And one thing that we've consistently seen, we've been doing screening for 9 years now, and what we've consistently seen is that teachers report more concerns around those internalizing behaviors than externalizing behaviors. So externalizing behaviors are things like getting in arguments. The example that we give a lot in schools is the student throwing a chair, or the student who can't solve conflict with peers or adults. And it's important to note that we spend a lot of time talking about these problems in schools, right? These are the behaviors that typically lead to suspensions, lead to discipline. But really what our teachers are telling us is that they're more concerned about the internalizing behaviors than they are with externalizing. And so I think often in our conversations around externalizing, we run the risk of overlooking those internalizing students and really supporting them, because the externalizing behaviors are really demanding our attention in the moment. So I wanted to bring this up to highlight the fact that we've seen this year after year. There's other national data sources that also support this trend. And I think going into next year, we certainly expect to see huge spikes in these internalizing behaviors. Perhaps both, perhaps we'll see increases in both categories, but we want to be intentional about how do we support those internalizing students as well. And the good news, to Sharon's point, is we know that the things that we're doing in schools when schools are open actually are helping. And so this is an example of students, the same students over 3 years. When we have positive school climate, when we have screening going on, when we have teachers who are fluent in developing support plans and referring kids to services to get the more intensive supports that they need, those kids who are identified in the fall with risk, that you can see their scores on average go down. So they go into the green range, which is good, which is low risk. And then we see that maintenance between fall 2018 and fall 2019. And so this, again, is a trend we've seen repeated. And we use this to kind of reassure educators that we know what works. We have to continue to find a way to do what works virtually. And that is challenging, but at least we know the systems that can help. So, and equity, of course, is on the forefront of all of our planning in the Boston Public Schools, and thinking about where are our gaps in equity and how do we continue to ensure that all of our services and supports are available to our students and families with the highest level of need. So one thing we're really interested when we think about this work is screening. Screening can be a controversial issue, right? We're labeling students when we screen. And I think what's interesting in our outcomes is the ability to look at trends in those changes in behavior. So when we disaggregate our results by these different student groups, English language learners, race, ethnicity, and special ed, we see the same pattern, more or less, happening for all of our groups. There are slight differences and certainly gaps that we are looking at and intentionally addressing in our systems. But the ability to look at these long-term outcomes and really see the differential impacts that our programming has on these groups allows us to have more confidence in the systems that we're building and how to support students in school. One of the things with our screener that we've used for the last 9 years, we have primarily used teacher ratings. And so if schools remain remote, teacher ratings will not be very helpful. We're not collecting teacher ratings from remote instruction. However, this does present an opportunity for us to really start to collect child self-report and or parent report and really amplify those voices that are traditionally lost when you use something like teacher report. So we're excited for that. We have already talked about a lot of challenges. One of the challenges with planning is that all states were waiting on the federal government to make some decisions. All school districts are waiting on the state departments of ed to make some decisions, and then all schools in Boston Public Schools, that has 125 different schools, all schools are waiting on the district to make some decisions. And so there's just a lot of unknowns right now. And so we are doing our best to plan for every possible scenario so that whichever one happens, we will be prepared for. I mentioned technology was a huge challenge in our district. We did not have one-to-one technology. And simply providing the technology, frankly, wasn't enough because students, families, and staff didn't know how to access it, right? As compared to districts who were already using one-to-one technology. Capacity is also a challenge that Boston faces. I would venture to guess every district faces this. I am a huge believer in school mental health, and I think most districts do not have the resources in terms of district employed providers and partners that are really necessary to meet the student and community needs. So that is a challenge that we faced pre-COVID, but certainly continues to impact us as we go into the next school year. And then coordination of services, we touched on this, but we're lucky to have so many partners and really think about expanding access to providers, but that comes with a great deal of coordination tasks that are not easy and not necessarily built into job descriptions at the district level. And so working really closely to coordinate our services to make sure we're not, students aren't accessing services from 3 different providers where another student can't access any, things like that. But we have seen a tremendous amount of opportunities and really bright spots throughout all of this. Increased relationships with families has been one. In order to provide services online, we really had to have a strong connection with families and caregivers. And so there's been more time to actually develop those relationships. Whereas if you're working only in the school building and the parent never can come to school during the work hour, that can be strained. Telemental health has also been a real opportunity and bright spot. I've heard of a few cases where providers have said, I had students who I would see in school for counseling and they really didn't open up or they didn't want to be there. And with telemental health, they've opened up more and they've felt more comfortable engaging in the therapeutic process. So I think that's not true across the board, certainly, but that is true for some cases. And so I think we're going to have to, even when COVID is over or when we're able to go back to in-person, I think there's still opportunities to use telemental health to our advantage. There's also much more widespread recognition right now of Maslow before Bloom. I don't know if that's language people are familiar with, but Maslow's hierarchy of need before Bloom's hierarchy of instruction, right? The academics are huge. They're a need and they're pressing, but we won't be able to do them well if we don't have well-being. And then partnerships. CBHM was developed in partnership with Boston Children's Hospital, Boston Public Schools, and UMass Boston. But we have so many more partners than that, and we are grateful for all of them, including the students and the families that we are honored to serve and work with, as well as so many institutions here in Boston that provide services within our schools or help us with research and the data side of things. And so I have to include my gratitude for all of my partners, including Jen Green, who helps us on the research committee at CBHM. And we're excited for the 2021 school year. And we're thinking about how to continue those practices that we have been doing well in schools, and then how to also amplify those practices and make sure there's increased capacity. We do know from school surveys that a great deal of parents of students who didn't receive services also noted these concerns. And so how do we just make things universally available to anybody who needs them while still having capacity to do this? One challenge I will also highlight for those of you in schools is that in the fall, in last school year when we switched to remote, special ed testing kind of had a hiatus, right? And so staff were able to provide services and really ramp up the service delivery. As we move into next school year, school districts will have to continue to do assessments as well as services. And so balancing that and being able to do both will certainly be a challenge given everybody's capacity. But we're excited to take that challenge on and to work with partners and come up with some new innovative ways to address that challenge. So thank you. I will stop my sharing now.
Great, thank you so much, Jill. And we have a few minutes to take some questions. And the first one is actually for you, Jill, as a follow-up, which is a question about whether you can talk about what drove the decrease in internalizing behaviors that you were showing in your slide?
Yeah, I think, so there's two things. We have, in comprehensive behavioral health model, we have tier 2 and tier 3 interventions going on. And so students who might be identified early with risk could be referred to either a check-in, check-out type intervention. They might be referred to a social skills group. Depending on the individual student and the other data available about that student, teams would work to create a support plan. We know that those interventions are happening, and I would love to tell you that those interventions are the reason we're seeing that decline. But I think it's huge to note that all of the tier 1 interventions we're doing are likely also contributing to those decreases. And so we think of PBIS or culturally responsive PBIS or social emotional learning curricula. That's a tier 1 intervention, but especially with those internalizing students who might be more anxious when, leaving the group to go to a specific intervention or being called to a smaller group, those students being able to access that support in the tier 1 and throughout their school day is definitely playing a part in those decreases as well. And so it's really a combination of those. We think it goes back to that comprehensive school mental health model of having the supports in place for everyone.
Thank you. If there are other questions that people have, feel free to put them in the Q&A. And I have a couple of questions. So a question for Chiara, you talked, I thought it was really interesting. Your talk was great. And I thought one of the things that was really interesting was your discussion of the balance between connectedness and privacy and time apart and time together, and some of the challenges around seeing everyone on a screen in a family, or not being able to see everyone crowded into a screen, that are coming up in the context of assessing safety and suicide, and in the context of Latinx families that are recent immigrant families, and some of the complexities that you described. And I was wondering if you could talk a little bit more about strategies that you've seen clinicians use, or things that you might recommend clinicians use or not use in thinking about this context, and how to address the needs of the youth and families that they're working with.
Sure. Well, I think speaking to that piece about connectedness and privacy, I thought about that a lot, because often one of our recommendations when a child is at risk for suicide is that we want to be sure that means are restricted in the home. So especially access to firearms, prescription medications, and we want parents to monitor what their kids are doing. But thinking about that in the COVID context, and generally with the needs of adolescents and adolescent development, you also, I think, as a family provider, don't want to err too far on the side of parents completely restricting any access to sort of space and privacy from their child. So I think that some of the things, thinking about especially families that are in small spaces and intergenerational households, it might just be about, setting some family routines where there can be quiet times, where an adolescent, for example, maybe, is with the family or is in a room with the door open, but they really have their own space during that time, where they know they're not going to be asked to do a chore or to answer a question or anything along those lines, where that's really their time. I think especially given the demands of technology, and that we know it as adults how draining it can be to be online all day long. For youth, I think we really need to build in those breaks and those routines so that they can recover and kind of get that balance. But I think, thinking outside of sort of space in a physical way, I think is a really key piece, because families don't necessarily have that option. And many families, are in situations that they can't social distance even from other, families or other family members effectively. And then I think the other piece is really, for routines, thinking about things that are sort of lower barrier for families. I mean, I think, having very ambitious schedules and things like that might work for some families, but it's, it's another sort of piece for parents to address. And so I think really working with families more around what's one routine that they can develop together, something that everyone in the family can look forward to connect. And it might just be, a card game on one particular day of the week, or something, movie they watch together. But having something that's sort of at a set time, we know that those rituals are really helpful for kids, even kids that are at a stage where they might not want to connect with family as often. So thinking of those interventions, I think that can be easier in the short term when people are dealing with so many stressors.
Thank you. Thanks so much. And Sharon, a question for you. You were talking about different approaches to addressing mental health needs, and I was wondering if your approach was different or your recommendations are different for schools that are reentering in a remote model versus a hybrid model, and if there are different things that schools should be considering depending on the context of their reopening plan.
Yeah, for sure. And I switched platforms because my power went out, so hopefully you can hear me okay by phone. Great. So certainly, this is a good example, unplanned, but technology can get in the way. And we know that inequities also really have led to disparities in the ability to access learning environments, and that holds true for being able to access mental health supports as well. So when we do have young people where they're going to be doing exclusively remote learning, we have to be creative and ensure that A, they have online access, B, that our families, students, and providers are familiar with the use of distance technology to provide supports, but also that we as providers and systems are reaching out to students and families. And if we are not able to do it virtually, you know, we've had a lot of creative student support teams who are meeting families at the meal pickups, for example, if they're coming to get meals for breakfast, lunch, dinner during the day. So a lot of creative ways of reaching out, but some of the basic tenets remain. We need to be conducting social emotional learning supports for all young people, whether at a distance or in person, and we need to be supporting transitions given that the learning is so dramatically different no matter what the context is right now.
Thank you. And I think there's a final question here for you, Jill, which is about what makes coordination of services so hard. You can call that out in the presentation that you were giving, and so maybe you could speak a little bit to that.
Sure, I think that might be one unique to districts like Boston that are so large. But in our system, for example, we have 125 schools. We have over 20 different partners that provide services within schools. And in some schools, we have a combination of providers within one school. And so keeping track of who is where, sometimes one agency being in a school means that they are sending 3 different providers each on 1 day a week to the school. And then as a district, we're sending another provider there 2 days a week. So service providers, whoever is attached to a school might not even be there on the same physical day during the school building. So maintaining that close connection of service providers and case lists, record sharing, documentation, all goes into the coordination. We have some systems in place in Boston. So we have a collaborative that brings together all of our mental health partners. We have some standards of practice and some things in place to support that coordination. But again, all of those partners pivoting so quickly also increase that coordination need.
Thank you. And we're right up at the end of the time now. And I think we lost Sharon because she lost her power again. But she has sent resources and we will make those available. And this webinar, the webinar has been recorded and will be posted on the BU Wheelock webpage for the webinar series. And thank you to all 3 of you for speaking and for joining the webinar today and for sharing your perspectives and the important work that you're doing. I'm so thankful to you for joining us this afternoon.
Thank you.
Thanks so much. Take care.
Thank you.